I want to thank Corey for the invitation to join you all today. I want to thank you all also for staying for the last session of the day. I think that in the last several decades anyway, the developments with immunotherapy in lung cancer, certainly, or in all cancers really, in lung cancer certainly has become a very progressive development and is very sexy right now in terms of how we move forward with our novel therapies. So I have no disclosures. So we hope to cover today, and I'm going to be very basic in terms of, I'm not going to talk about the therapies at all, that's going to be discussed in the next two talks, but why it is and how it is that we evolved into understanding that immunotherapy can be beneficial and what is the immune context of these tumors. And we'll talk about how the tumors and the immune system interact, how the prognosis can be impacted by the tumor microenvironment and the interplay between the tumor and the immune system. And then we'll talk very briefly about the various approaches to immune therapy. So first of all, how do we know that immunosurveillance is even an important concept to consider when you look at cancer? If you look at patients that are HIV positive, right, and have profound T-cell dysfunction, those patients are at higher risk for developing virally mediated tumors. So this does suggest that there is immune surveillance there that would prevent tumors from developing had they not had HIV infection. Through various complex immunologic, cellular, and molecular biology approaches, we now have a very good understanding that tumor-associated antigens are very common in many different types of tumors, very early on identified in melanoma and renal cell carcinoma, and now extending out into many other different types of tumors. When we look at lung cancer specifically, we know that patients that are solid organ transplant candidates, not candidates who have received solid organs and are on chronic immunosuppression, those patients actually are at higher risk of developing lung cancer than patients who are not immunosuppressed. And importantly, for two reasons, paraneoplastic immune system disorders that occur in lung cancer, most commonly seen in small cell, such as the anti-Hugh syndrome, where there is believed to be cross-antigen presentation of the tumor itself with the with the neurologic cells, particularly the Purkinje cells in the cerebellum, where the anti-Hugh antibodies will bind to that and cause the neurologic condition. So this shows that not only that there's immune response being generated in some of these patients, but importantly, compared to where we're looking at things today, which is mostly T-cell mediated, this demonstrates that there can be B-cell mediated impact on tumor growth, progression, and responses. So what does the tumor microenvironment look like? So you have basically, you could have components of the immune system scattered throughout the entire tumor. But for the most part, a lot of it is concentrated at the interface between the normal lung out here, or the normal tissue, and the tumor itself. Within this boundary between the two, or the interface between the two, you can actually have what are called tertiary lymphoid structures. And within this are all basically with the cellular components that are present in a lymph node. So you can have dendritic cells, you can have regulatory T cells, macrophages, B cells, and all those particular components. And then there's lots of crosstalk between the tumor cells themselves and suppressive or activating factors that may be there, and then suppressive or activating factors that may be either in isolated cells that are in the stroma or in the tumor, or more importantly, that are present in these tertiary lymphoid structures. And what we're just trying to understand, or starting to understand, is could there be differences in the environment between these tertiary lymphoid structures and even regular lymph nodes or other regional components of the immune system. This is just an example of one of these tertiary lymphoid structures. So right here in panel A is a tertiary lymphoid structure. These are scattered dendritic cells within this tertiary lymphoid structure. Lots of B cells present within the tertiary lymphoid structure. These are dendritic cells, and these are also just some more macrophages. And this one's actually showing how the macrophages interface with the T cells within that tertiary lymphoid structure. So a very complex components of the immune system present here, again, just as you would see in a lymph node. So what are all the phases that are necessary for an immune response to be generated? When you look at the steps that are involved from the original tumor itself, where antigens are actually recognized and or produced, tumor then have to go through antigen presentation. Once antigen presentation on the dendritic cell or the macrophage occurs, you then have to have activation and priming of the T cells. If this occurs outside the environment of the tumors, for example, in the regional lymph node, those cells then have to, the activated primed T cells have to then travel through the circulation, get to the target. They have to get through the vasculature into the target. Then once they're in the target, they then have to maintain that activity and actually have their cytolytic impact on cell function. And all along each one of these steps, you can see the light green versus the dark green. The light green are activating pathways. The dark green are inhibitory pathways. And so at each one of these steps, there are profound levels at which you could either activate and or inhibit this entire pathway from release of the antigen to actually activating the T cell. So you could see how thinking the development of immunotherapeutics, at what point and at what level are you going to actually try to have your impact? So we then look at how prognosis may be impacted by just the immune response and native immune responses that are present in tumors. This is a study where they basically took resected lung cancers and they differentiated squamous versus adenos, and they looked at survival. And so basically they showed that in patients that had high level of infiltration of the tumor with tumor-infiltrating lymphocytes versus low level, there was actually a difference in survival between these two, suggesting that if the T cells were there would be an improvement in survival. Interestingly, I'm only showing you the squamous. There was a difference in survival here in squamous. In this particular study, there was no difference in survival in adeno based on high or low level of TILs. Again, for purposes of time, I'm not showing other studies. Other studies have shown that CD4 cell infiltration improves survival in infiltrating if there's high levels versus low levels. And so any of these T cell components that are in the tumors, if there is a native inflammatory response is present in the tumor, there appears to be improvement in survival. It's not only the T cells. This is a study where they took resected samples again, and they looked at dendritic cells and T cells. So in this particular graph here, high levels of expression of high levels of infiltration of dendritic cells in tumors versus low level had improved survival. This just confirms the CD8 T cell infiltration improved survival with high levels versus low levels. And down here, this is basically just looking at whether tumors had high dendritic cells and T cells and the various permutations of those. And basically high T cells, high dendritic cells had the best. Low dendritic cells, low T cells had the worst survival. So dendritic cells interfacing with T cells, at least at the level of immunohistochemistry, does seem to matter in terms of survival. But it's not only whether they're present. This study actually looked at where are they present within the tumors. And so in this particular study, it was actually all advanced cancer patients. These patients had either bronchoscopic or transthoracic needle biopsies performed, and they looked at survival based on where those immune cells were located. And if the macrophages and T cells were highest in these, what they considered nests within the tumor, as opposed to presence within the stroma, that those patients had the highest survival. That's this curve here. If the dendritic cells macrophages and T cells were mostly located in the stroma, those patients had the worst survival. So it's not just the presence of them, but it's also where they're located within the tumor that can change the survival. B cells also seem to matter. I mentioned the anti-Hughes syndrome and those paraneoplastic syndromes. It does suggest that B cells matter. This is a study where they looked at patients, early stage is this side, late stage is this size. It doesn't matter whether it's early or late stage. Patients here that had high B cell infiltration had better survival than those with low. This just confirms what I showed in the last. This was looking at macrophages, high macrophage versus low macrophage. And this is combining both, if they had high macrophage and B cell, had the best survival versus low macrophage and B cell infiltration. So it's not only T cells and dendritic cells, but B cells. So it's looking like all components of the immune system, if they are present within the tumor, appear to be able to impact survival. What I don't show in some of these studies is natural killer cells also have been shown to impact survival, as well as tumor-associated macrophages. This particular study looked at regulatory T cells. So regulatory T cells are negative regulatory cells present within the immune system. They basically express one of the inhibitory molecules called CTLA-4. They also express high levels of TGF-beta and also IL-10. And if these are present in high levels within the tumor, whether you look at overall survival here or relapse-free for survival, in those patients who had resection and had high levels of T regulatory expression infiltration within their tumor, those patients had a much higher, had a much lower survival than those patients who had either intermediate levels or very low levels. Interestingly, when you look out at longer time frames, while it was not statistically significant, it did look like those patients with even the lowest levels of T regulatory expression did separate out with a better survival compared to those with an intermediate level. So negative regulatory components of the immune system in the tumor can also impact survival. So hopefully I've impressed upon you that this is, based on these studies, this is an incredibly complex environment where the tumor and the immune system are interacting with one another, impacting one another's function, and ultimately likely are impacting prognosis and outcome. So how can we exploit some of these pathways that are present to a therapeutic advantage for the patients? Obviously, a lot of people have talked about the immune checkpoint inhibitors, and we're going to, the subsequent lectures will talk more specifically about the trials, but when we look at the pathways that are most investigated now from a therapeutic drug delivery mechanism right now, the pathways are the PD-1, which is programmed cell death 1, CTLA-4, which I mentioned before, another pathway called TIM3, of which there are currently none available for investigation in a clinical fashion. And then each of these bind to their cognate receptors on either the antigen-presenting cell or the tumor cells, and when they do so, that modifies T cell function. So this is just an example of all of the potential positive and negative regulatory pathways that are present on T cells that on this side is the antigen-presenting cell or the tumor cell, on this side is the T cell. So you can see that any one of these pathways potentially could have the pathway to either enhance activation or to inhibit their activation and prevent them from becoming active against the tumor. The ones we know specifically that have worked, investigated most thoroughly are against the CTLA-4 with tremelimumab and PD-L1 with the agents that we've talked about. So let's talk specifically about PD-1 because this is where most of the pathways most of the studies have looked at. And they investigate tumors broadly across biopsies in various studies, whether it's bronchoscopic biopsies, transthoracic needles, or surgical biopsies. Anywhere from 20 to 60% of tumor cells have been shown to express PD-L1. Recognizing that, I'll show in the next picture, PD-L1, the ligand, is actually expressed on the tumor cells. PD-1 is what's expressed on the T cells. So high levels, in some studies, high levels of expression of PD-L1 on the tumor has been associated with a worse prognosis, but interestingly, that has not been entirely consistent. And part of that may be that high levels of expression on tumors may, if you can inhibit that high level of expression, that may actually improve prognosis because it will enhance the chance that the tumor will respond when the inhibitor is given. When you look at CD8 cells, now PD-1, which again that's what's expressed on the T cell, high levels of expression of PD-1, when you take those tumors out, extract them from patients, and try to look at activation of those T cells ex vivo, has basically been shown those T cells have impaired function. So PD-1 through binding through PD-L1 and also potentially even its expression at the surface impacts their overall function. And interestingly, the level of expression of PD-L1 may be impacted by the various other molecular changes that are occurring within the cells. So for example, PD-L1 expression has been shown to be higher expressed in adenocarcinomas in those patients with EGFR mutations. PDL on T cells have actually been shown to be more highly expressed in patients who have KRAS mutations and are current smokers. And so there are other mechanisms that feed into this inhibitory pathway that are present within tumors that lead to even further complex understandings of the environment in which we may be able to impact. So it's just a quick picture, just demonstrating what I was mentioning before. So the two pathways, I'll come to PD-1 in a second, but CTLA-4, while there is a actionable pathway right now, it's important to understand that CTLA-4 works at the level of antigen presentation, not at the level of the tumor. And so CTLA-4 can inhibit the ability of the dendritic cells to activate the T cells, and so the T cells do not become primed and activated. PD-1 and PD-L1 acts at the level of the tumor cell. So once the T cell is activated and tries to get into the tumor to become active, once PD-L1 and PD-1 bind with one another in the tumor at the level of the T cell becomes inactive or is exhausted. So what is necessary for PD-1 or PD-L1 inhibition pathways to actually work? So you obviously have to have the PD-1 expression or the cognate receptor present on the T cell. You also have to have the ligand presentation on the tumor cell itself. And then the T cells have to be able to get into the tumor, be there, and actually be active. If the T cells have not been primed and activated and then inhibited, they will actually not become activated once they're within the tumor microenvironment. So this is actually just an interesting flow diagram to think about. So the concept is here that you have, again, just as I mentioned, you have to have the activated T cells present within the tumor and actually have them deactivated in order to have the PD-L1 inhibitor work. So in the first graph here, you have a patient who has a strong endogenous anti-tumor response. That tumor has upregulation of PD-1, which then when you administer this, because the T cells are there and there is an endogenous response, you can actually get a response within the tumor. If the tumor has a very weak or has no inflammatory response, has very little T cell infiltration, then there is very little PD-L1 or PD-1 expression. As a result, administering the PD-1 to the tumors, you may not get any response at all. So this raises the question, if we were able to identify patients who had a weak endogenous tumor immune response or inflammatory response, can we enhance that, get them to generate a PD-L1, PD-1 expression, get more infiltration into the tumor of activated T cells, then potentially the PD-1 inhibitors could have more effectiveness. And of course, I'm sure some of these studies will be reviewed. We know how effective this has been in a variety of different cancers, from melanoma to now lung cancer. So it really has changed the paradigm of how we think about the modalities available for patients in therapy. Looking globally at cancer immunotherapy, we talked about the checkpoint inhibitors. You can also do adoptive immunotherapy by ex vivo activation of T cells, be it dendritic cells or T cells, administering them. Monoclonal antibodies, we now know, particularly with experience in breast cancer, can be effective in cancers. Cancer vaccines, by generating CD4, CD8 T cells, can be very effective. And non-specific immunotherapies that just generate a global immune activation, such as interleukin-2 and renal cell cancer. So these are kind of the broad categories of which we could administer immunotherapy. But what about the immunotherapy trials that have been done so far and reported in lung cancer? When we look at the vaccine trials that have been presented, the START trial and the MAGRIT trial, which are both, one is against MUC1 antigen and the other is against the MAGE-A3 antigen, neither one of these actually showed any survival benefit. And so you ask the question, why not? You're generating these CD4, you're generating these CD8 cells at the point of your vaccine. I go back to the original slide that I presented, and this is probably why. So in each of those studies where you're administering a vaccine, you're working at the level of this point in the immune response that's necessary to get an anti-tumor immune response. So you're giving the antigens, you're giving the dendritic cells, you're giving whichever administered to the patient, and so you're priming and activating the T cells at the location where they're being generated, but then you have all these other steps that have to be addressed after administration of the vaccine. So it does not do any good to activate CD8, CD4 T cells if those cells, after they get the vaccination in their arm and they get activated locally or get activated in the lymph nodes, if they cannot then undergo appropriate trafficking through the vascular system, trafficking through local lymph nodes, trafficking into the tumor, and along those steps have all the appropriate pathways to allow them to maintain their activity and actually then have an anti-tumor immune response, is probably why these studies have not been successful. So we have to be more multimodality approach within our immune approaches in order to make sure we can deliver these cells that are necessary to the location that's necessary. So how do we make immunotherapy more successful? I think we just have a very, well, certainly further along now than we were 5 years ago. I think what we're going to find is that the immune environment for every single patient is going to be unique. And so this concept of precision medicine is going to, I think, pervade into immunotherapy as well in terms of how we understand which therapies may be best for the patient. Does the primary tumor microenvironment differ from local nodal environment, differ from metastases? And will there be differential responses based on the immune environment in each of those locations? Does the stage of disease matter? Is early stage versus stage 2, 3, and 4, are the immune microenvironments different, and will we need to tailor our therapy accordingly? And can we combine therapies? So there's been studies looking at giving radiation therapy to patients where that may actually generate a localized change in the immune response, may generate new tumor antigens, and as a result then allow for more immunotherapeutic approaches to be administered. So this is where we all want to be. This is just an example of nivolumab. So in this particular patient and in patients where we're seeing responses on the PD-1 inhibitors, it's probably because that's the primary immune pathway that's being impacted in these patients. But again, as I said, I think to more consistently show immunotherapy in combination with other therapies to be effective, we're going to have to better understand the individual immune environments within patients going forward in precision medicine. So thank you.